Hi, my name's Jonalyn Brown, and I'm the Vice President of Operations for Consonus Rehab. As you all know, I'm sure, in late August, CMS released new guidance for nursing homes to aid in our efforts to keep COVID-19 from spreading to residents and frontline staff. Parameters surrounding surveillance testing, enhanced infection control policies, and a new facility survey tool were all included in this release. Today I'm joined by Diaz, Vice President of Clinical Services for Marquis Companies. She's responsible for clinical services and regulatory compliance for our 26 skilled nursing facilities and assisted living facilities, and has played a vital role for Marquis throughout the entire pandemic. Today we'd like to talk about the importance of surveillance testing, the steps included under the new testing requirements, and how this impacts us as providers in senior care.
Thanks, Jonalyn. As new rules are released, it's not uncommon to see differing interpretation of the same rule or policy, which creates its own challenges in adopting and implementing standard procedures to support that rule. We've identified 3 key definitions within the testing requirements that, depending on how you interpret, could have significant impact on how providers choose to respond. These definitions are for what's required under surveillance testing, the definition of facility staff, and outbreak testing.
Let's start by clarifying those definitions. First, what does surveillance testing mean, and why is it so important to us as senior care providers?
By definition, surveillance testing is the routine, scheduled testing of facility staff based on CMS or state directives. This testing is not related to a positive employee or a positive resident, as that would come under our outbreak testing definition. What's most important is to understand what surveillance doesn't mean. It doesn't mean we test everybody. We test a subset of population, our staff, to determine what the surveillance or probability of an outbreak is. Our staff are our only connection between the community and our residents, for almost all of our residents, and surveillance testing helps us identify those possible asymptomatic positive staff, which is a leading driver to facility outbreaks. And it really helps us focus in on our testing resources to the group that really needs to be tested under surveillance.
CMS and a majority of the states have set requirements for surveillance testing, and providers need to be aware of both, right?
That's correct. It's very important for providers to know the guidance based on the state in which they operate, as well as the guidance for nursing facilities from CMS. The basic CMS outline is based on a county's positivity rate. That is, the total percent of positive tests of all testing completed in that county. If the percentage of positive tests is less than 5%, it will be indicated by the color green. That is, monthly testing is required. If it's between 5% and 10%, indicated by the color yellow, then weekly testing of all staff is required. A percentage of positive tests that are greater than 10%, indicated by the color red, requires us to test our staff twice a week. Note that CMS has also added an adjustment recently for those rural counties in which we have very low population counts. Due to this adjustment, it's important for providers, when they go to CDC to check their county positivity rate, to pay attention to the color more than the number. For example, a very small rural community may show 12% positivity rate, but may be by color yellow, which is once weekly versus twice weekly. Some states, such as California, require a higher frequency of testing than CMS does. California requires 100% of staff testing weekly ongoing, so that it's very important if you're a provider to be aware of both the federal and state regulations on surveillance testing.
What should a provider think about when putting together a comprehensive testing plan?
A provider needs to think about their testing sources, whom to include in the testing protocols, what are the triggers for when to test, and how to report the testing that you've completed, and ultimately what to document in order to demonstrate your compliance with the rules. You need to make sure that you have a well-organized and structured process for tracking, logging, and reporting all the testing completed by your facility.
Let's take those individually. What variables did Marquis consider when trying to identify a primary testing source?
We looked really for the quick turnaround. What's the consistency? We wanted one source of lab testing. And ultimately, obviously, what is the expense? In each region in which we operate, we asked ourselves what was our testing sources in that area, what is available, what was reliable, and what was the turnaround time for the tests. That was our biggest key. We ultimately found out the point-of-care antigen machines that were sent by CMS created some larger operational issues with efficiency and accuracy, and we chose then a lab in which we were able to solidify a 48-hour turnaround time for all of our testing.
You mentioned expense. One concern surrounding surveillance testing is sustainability due to the high costs associated with testing. Thankfully, CMS released funds to help cover the testing. Do you have any recommendations or suggestions on how to justify and utilize those funds available?
The financial burden of testing without the CMS funding is simply not sustainable. That's why the tracking of all your costs associated with these items is so important, so that we can demonstrate the utilization of the funds as they were intended by CMS.
As we think about expense, it brings up a good question about who all to include in the testing protocols.
It gets a bit complicated. Staff, as defined by CMS, includes employees, consultants, contractors, volunteers, and caregivers who provide care and services to residents on behalf of the facility, and students in the facility, either with a nurse aid training program or affiliated academic institutions. CMS has extended the definition to be any person who is within your facility interacting with staff or residents in your facility's setting. But we also need to be careful. This may not also include delivery drivers. If they're just dropping something off and leaving, such as a pharmacy delivery, UPS delivery, flower delivery, that is not included in the CMS definition.
That's a really good point. So by that definition, whose responsibility is it to ensure that this testing has been done for all those types of staff?
Ultimately, it's the facility's responsibility, either by requiring the proof of testing, which is very difficult to track, or including them within your facility testing rotation, which is much easier to track, manage, and document. This is the system that we have implemented and we encourage. We notify the person who meets the definition of staff, inform them of our testing schedule. They are required to complete the testing with the facility or provide proof of testing, which has been completed within that same week or around those same days.
Okay, so how are you handling your therapy and pharmacy partner? And what if the vendor supplies the testing?
Even then, as a provider, you are still required to document. That's why, from a compliance perspective, we've made it much easier to include our therapy teams in our facility testing so that we've got it all well documented. It's under one testing source and maintained in accordance with the CMS and or state required frequencies based on our positivity rates and our health authorities.
So we've talked a lot about surveillance testing. We know that outside of routine testing, there are other times when you'll need to test as a provider. What are some critical steps you've taken when you've identified a positive employee?
Anytime that you have a positive employee, any employee, or a positive resident, you will need to move into what's called outbreak testing. An outbreak is defined by CMS as a new COVID-19 infection in any healthcare personnel or a new onset in the facility of COVID-19 infection in a resident. When an outbreak occurs, this requires a testing goal of 100% of staff and residents. Ultimately, the target is within the first 72 hours of that positive first test. Then you will move into weekly testing, usually between day 3 and day 7 every week, until we have a period of time of 14 days without any further positive testing in either a staff or resident.
So once you've figured out your testing source, who to include in the testing, and how often to test, what are the key questions senior care providers should really be thinking about or asking themselves?
Right. Providers need to understand when to report the tests, how to document the testing in order to demonstrate their compliance. which is a huge topic for a different video. Additionally, I think there are 3 questions that providers should give a lot of thought to. First, do you have an organized and structured process for testing by weeks, dates, and listings of names with all of their results? Second, how do you organize this within your facility? And third, surveyors are going to be reviewing your protocols. Are you ready for that?
Those are 3 great takeaways. Thanks, April. We've covered a lot of ground here, and I hope this overview has been useful to you. Obviously, though, we've just scratched the surface, and Consonus can help you better understand and navigate these new COVID testing requirements. So whether you're an existing customer or are considering a new partnership with Consonus, please don't hesitate to reach out. We'd love to hear from you.